Good afternoon. I'm Aloke Finn from CB Institute in Gaithersburg, Maryland. I'm going to talk to you about MagicTouch Sirolimus Coated Balloons for PAD, experimental data, and rationale. These are my disclosures. So what are the elements of an effective DCB formulation? We certainly have to deliver large quantities of the drug within seconds. That drug has to stay there and distribute in the media in the first few days. And we've got to get therapeutic levels that are maintained for more than 4 weeks to really have an effect on the anti-restenotic or the restenotic cascade. It must allow for rapid healing as compared to drug-eluting stents. And of course, we have to have effective drug delivery to the target tissue while avoiding non-target effects. Why do we need a sirolimus DCB after all? We have plenty of paclitaxel DCBs out there. Well, as you all know, sirolimus is the gold standard for coronary artery disease treatment via DES, and it's proven to be safe and effective with no reported effects on mortality, etc. Paclitaxel modifications, that is the crystalline form, mean coating integrity and transfer, as we all know, are variable with substantial portions lost in the downstream blood and tissues. Loss of paclitaxel into the body remains a significant safety concern, which was further exacerbated by the Katsanos analysis published in JAHA in 2018. And our group, as well as others, have shown significant effects in terms of downstream findings in preclinical models for embolized paclitaxel and downstream skeletal muscle beds after treatment of SFA. As well, after coronary angioplasty, it's well known that paclitaxel can impair coronary flow reserve and cause downstream slow flow, probably because of shedding of paclitaxel to downstream beds. So the MagicTouch Sirolimus Coated Balloon is an interesting and important solution. It's a sirolimus coated balloon that treats coronary artery disease or peripheral vascular disease. It can deliver the drug within 60 seconds. And essentially what we're talking about here is we're talking about a drug-coated balloon which has submicron phospholipid particles which themselves are encapsulating sirolimus and deliver it to the arterial wall effectively. So what are the problems with sirolimus coated balloons? Why do we not have them so far? Well, it's difficult to enhance tissue absorption. It's difficult to get sirolimus to enter the arterial tissue within 30 to 180 seconds of balloon dilatation. So therefore, you need some sort of instant glue that requires to transfer the drug from the balloon to the tissue efficiently. And of course, we need to extend tissue retention. It must be released over time. This is data, experimental data from the porcine model where I'm showing you how the MagicTouch Sirolimus Coated Balloon works in the porcine coronary artery model. Here, we're showing Raman spectroscopy of encapsulated and free sirolimus. And you can see here the ratio of encapsulated to free sirolimus in the graph shown. You can see how the sirolimus nanoparticles partition basically into the adventitious, somewhat in the media, and the intima after injury. And slowly over time, we have a transition from encapsulated to free form of sirolimus over the course of 28 days. This is exactly what we'd like to see. And this results in sustained arterial wall sirolimus tissues. This is data from the porcine coronary artery model showing you the drug levels of sirolimus in the arterial wall at different time points. You can see release is sustained out to 60 days with this MagicTouch solution, which is certainly satisfactory for causing anti-restenotic benefit. We did a preclinical swine ISR model where we basically implant Yorkshire domestic swine with a BMS implantation. We do a angiogram and treatment of the what I'll call an in-stent restenosis model at 28 days with a DCB or plain old balloon. And then we follow those out to 56 days where we euthanize the animals and look at the coronary arteries themselves for evidence of drug effect, as well as tissue and organs for downstream effects on potential unwanted effects. This is the 28-day histology of the MagicTouch 1X dose shown at the left and the plain old balloon angioplasty shown at the right. What you can see is this is treatment of the in-stent restenosis model. And what you immediately notice is that there's fairly good arterial wall healing, good reaction, no evidence of toxicity. And there is evidence shown in the arrows of some fibrin deposition consistent with drug effect at 28 days. You do not see that in the POBA arm. And in terms of histopathology, we don't show any difference in needle area, maybe probably because this is a low injury model. We're not going to see an effect on stenosis, but we do see a massive effect on struts with fibrin, much more struts with fibrin, a marker of drug effect in the MagicTouch 1X dose versus the POBA, suggesting successful drug transfer, which is effective in having biologic effect. Now, what about downstream findings? We looked in this model at a total of 84 sections of myocardium that were examined. There was no incident of myocardial infarction in either group. Microscopic scarring was observed in 2 downstream myocardial sections from MagicTouch and 3 sections of POBA. So essentially no effect on downstream emboli in terms of increased effect in the MagicTouch. And there was no direct visual evidence of downstream emboli, consistent with successful drug transfer to the arterial wall without the kind of reactions we've seen after paclitaxel sirolimus-eluting balloons. So in conclusion, I'd like to tell you that sirolimus is the preferred drug, there is no question, for intravascular interventions. Paclitaxel-coated balloons are limited by a high rate of distal embolization and loss of paclitaxel into the body. These concerns are certainly were highlighted by or heightened by the analysis of Katsanos, published 2018. The MagicTouch Sirolimus-coated balloon demonstrated successful drug transfer to the arterial wall out to 60 days with evidence of drug effect and no toxicity. Downstream emboli were minimal in the current coronary ISR study presented here. And I think this kind of data is a promising, it certainly represents that this balloon is a promising new technology for the treatment of PAD as well as CAD. So I'd like to thank you for your attention.
Thank you to Concept Medical and to the Linc Symposium for giving me the opportunity to present the 1-year results of the MagicTouch PTA XTOSI trial. These are my disclosures. XTOSI trial is a clinical trial investigating the efficacy and safety of the MagicTouch Sirolimus Coated Balloon in the treatment of peripheral arterial disease. It is a prospective pre-market all-comers single-arm trial. 50 patients were recruited. There were 2 primary endpoints. The first is an efficacy endpoint, which is primary patency at 6 months, defined as peak systolic velocity ratio of less than or equals to 2.4. The second is a safety endpoint, defined as a composite of freedom from 30-day mortality and amputation, and also freedom from 6 months target lesion revascularization. 55 patients were screened, of which 5 failed screening, because in 2 of these, the interventionist decided against using Sirolimus Coated Balloon. 1 failed to achieve adequate vessel preparation, and 2 patients had flow-limiting dissections. 50 patients were enrolled, in which 20 were femoral popliteal and 30 were below-the-knee patients. 40 patients reached the 6 months primary patency endpoint. 10 did not reach because 6 had died, 1 underwent major limb amputation, 1 was withdrawn due to target limb fracture, and 2 did not attend the ultrasound follow-up. In terms of demographics, these were high-risk critical limb ischemia patients. 90% of patients had diabetes, 1/5 were already on dialysis, and up to 1/3 had coronary artery disease. In terms of ASA scores, 80% of patients had ASA scores of 3 or 4. The majority of these were done for limb salvage, with Rutherford scores of 5 and 6 in 94% of patients. In those with wounds, more than half had Wi-Fi scores of 4 or more. In terms of the lesions treated, these were mostly long and hostile lesions. The mean length was more than 20 centimeters. More than 1/3 had occlusions. Stents were used in 8%, and 1/4 required retrograde access for wire crossing. This slide summarizes the 2 primary endpoints. The 6 months primary patency was 80% for the whole group and 88% for the femoral popliteal group. Now, obviously, different trials are not directly comparable, but just as a rough guide, the 88% 6 months primary patency for femoral popliteal group is similar to the paclitaxel drug-coated RCTs, including the Ranger SFA and Levanto Lutonix trials. The 6 months primary patency of below the knee was 74%, and this compared favorably to the paclitaxel drug-coated balloon single pacli RCT, in which the 6 months primary patency was only 42%. The 6 months freedom from major adverse events was 86% for the whole group. 12 months results are now available. And looking at the primary patency at 12 months, this was 67% for the whole group, 78% for femoral popliteal, and 59% for BTK. which is a very promising result at 12 months, considering that in a similar cohort in previous trials, the 6 months primary patency in paclitaxel drug-coated balloon group was only 42%. The 12 months freedom from target lesion revascularization was 90%. For femoral popliteal, it was 94%. For BTK, it was 86%. The 12 months amputation-free survival was 81% for the whole group. For femoral popliteal, it was 90%, and for BTK, it was 76%. To give more breakdown details on the amputation-free survival, at 1 year, there were 7 deaths. The majority, as expected, were from ischemic heart disease. At 1 year, there were 3 major limb amputations in total. In terms of toe pressures, there was also sustained and significant improvements in toe pressures for both femoral popliteal and BTK group. Clinical benefit was also seen. In terms of Rutherford scores, there was shifts in Rutherford scores from R5 and R6 to mostly R0 at 6 months in the femoral popliteal group. And similarly, in the BTK group, drops in Rutherford scores were also seen. So in summary, MagicTouch Sirolimus Coated Balloon showed promising 6 months and 12 months efficacy and safety for both femoral popliteal and BTK lesions in a cohort of patients which were high risk, mostly critical limb ischemia with hostile lesions. Thank you.
So
we are
thank
live?
you, Dr. Choke. So I can also see now we have all the panelists and also the live site in Berlin is ready. Ralf Langhoff and the team, welcome Ralf, and you're excited to see your case, and I hand over for the discussion, of course, to Dr. 𝐜𝐤𝐫𝐸𝐺 van den Berg, who is going to moderate the session.
Thank you very much, Dirk. Good morning, good evening, everybody. Hello, Ralf. I hope you're doing well.
Hi, Jos. I hope you're doing well. Thank you. Okay.
Okay. We're here with we're here with Ulf Teichgraber, Edward Choke, and Francesco Listro as panelists, including myself, and of course Dirk Scheinert is also joining us. Let us know what you have in stock for us.
Yeah. Okay. So good morning, everybody. Best regards to Leipzig and to the World Wide Web. So with me is Dr. Boral and Karin, who's just assisting us, and also Chrissy, who's just giving us all the materials we need. So maybe Dr. Boral can briefly introduce the case we've chosen for this session here today.
Okay, thank you, Ralf. Our patient, can I see the slides? Yes, our patient is a 72-year-old man with multifocal calcification on the left side. And we have here pain on the left calf after 30 meter. Next slide, please. The AB is reduced after examination with a treadmill test, and we know in the medical history that the patient underwent an arterial bypass and have lumbar stenosis, also a long QT syndrome with otherwise a healthy patient. Next slide. The risk factors maybe are the hypertension, the dyslipidemia, and the patient is a heavy smoker since 50 years, and we detect in the duplex sonography multifocal high degree calcified lesions on the left side we will now want to treat. In the course of the bypass graft aortic, we plan a left antegrade access with a 7 French sheet. And next slide, please. We saw here the duplex images, yes, with a high degree calcification in the proximal part of the SFA. Next slide. And it's also in the distal part. Next slide. And you see here the high degree velocity with over 5 meters per second, so it will be significant. Next slide. Next slide. Okay.
So maybe I can take over
yes.
briefly, because we just can show you what we already did. Just for the sake of time, we already started. So the intention was antegrade because of this arterial bypass. And due to the duplex findings, we just saw that calcified lesions, so we do have to do some vessel preparation. So we decided to perform atherectomy case here and just combine this with a drug-coated balloon. And so maybe we can switch to the live monitor and see. That was just the first run. We did antegrade puncture left side, so that was just what we also saw on duplex ultrasound. So high-grade stenotic lesion here, so nothing spectacular in terms of recanalization techniques, but a long lesion which needs some care. Outflow was good. Here's 3-vessel runoff, and I can show you the foot, which is, I think, a crucial point when you do atherectomy. So you want to keep all the vessels open. So you see here, so all vessels are patent. So we decided to perform atherectomy here with a HAWK1 device, a 7 French device, and we just have chosen the large one with a larger nose cone. You see here this device in action, so that's where the bites are taken, I would say. So and that's the knife here. And maybe we can show you what we already grabbed out of the patient and just maybe do the last 2 cuts with you. So I don't know, so maybe the camera can focus on this. So that's what we have already taken out. So a lot of, we always say noodles, udon, which we just here grabbed out of the patient. So a lot of calcified and organized fibrotic tissue here. So the last run, we did some orthogonal. Yeah.
Can you tell us whether you do a different kind of vessel preparation when using Sirolimus coated balloons as compared to paclitaxel, or is this more or less the same? And the second question, a little bit related to that, this is a very long multifocal lesion that you are treating. Would you do differently in a longer occlusion?
Yeah, so I think we have to gain some knowledge in terms of how to work with Sirolimus coated balloons. But anyhow, I think it needs vessel preparation. I think it's something you have to do, just pre-dilatation, and I think I would not change the concept that the PTA, that the drug-coated balloon is just not a PTA tool. It's just something to deliver drug to the wall. So that's why we always do vessel preparation with conventional balloons, atherectomy devices, or scoring or cutting devices.
Yeah.
So that's our strategy here.
Yeah. No, I think most of us will agree with that.
Mm-hmm. Yeah. So I just show you the runs, what we did already after atherectomy, so quite nicely. So we did several bites, and I think the last image is this one here. So we thought just maybe worth to take another brief cut here, and maybe just here where we just had still some haziness due to calcium, just to show you how this is going to work. So it's a monorail device, so maybe the second camera can focus here on this. We used a filter, so which I forget to tell you. So it's a Spider FX system, 6.0, which we put into the P3 segment to protect the outflow, which is mandatory when you work with HAWK1 device. So I will just insert this into the 7 French sheaths, and you always have to take care of the filter. So what we do, we attach a torquer here, so now the filter is fixed and cannot move into below the knee artery, so it's stable. We can have some overlay here, so yes, we thought just to maybe do something here. So it's single handed device, so that's the mechanism of action. And now I can talk to the direction, so it will cut on the left side of the image. And I gently move forward here. So the slowlier you cut, Also, the slower you move, the deeper you cut, and the less is the likelihood that you have peripheral emboli, because the material is stored in the nose cone here. I would just leave the middle part here because we did already some bites here, and maybe in this view we just thought that here we can remove some calcium. So the first passage was it was not so easy to get through, but after the first passage it was very easy. So we just had some effective reducement of tissue, and maybe just to this side another bite here. Yeah. Okay, so as we did some, so it's going to take some time, but not so much, because it's just not so long. Your question was just what we would do in a long occlusion. Yeah, depends a little bit if this is very calcified or softer tissue. So we already also have some experience with long occlusions, atherectomy, but then definitely you would maybe do this not on a Friday afternoon, because it's going to take some time. So I will just get another image here to see what was the last result before applying the drug-coated balloon. So we always combine the atherectomy with drug-coated balloons, I would say, in all of our cases. What you see here, also in the proximal part, is that you open in these calcified arteries vasa vasora. So this is just a free filling of the venola and venous backflow, which we are not afraid of. So it's not a perforation. It's just something you are going to open these calcified arteries vasa vasora.
But that's a sign that you need to stop probably, and not go any deeper.
Yeah. No, definitely not.
Okay. There's a question that I see from the people attending. Would Rotarex be another option in a case like this, or another atherectomy device?
No, for me not. Yeah, so maybe you could also just consider something like a jet stream device, which is just making a channel in the middle part, which definitely is something which is going to go faster. But here we just had the option just to address left and right, and also eccentric plug material here.
Yeah.
So it would be just also option for other devices, or like Phoenix. We have chosen a 5mm MagicTouch balloon here, and it's a 5x200. So maybe you could consider also take a 6, but the proximal part, but distally we just feel that a 5 would be just the better option here. What do you think?
I think this is. I would start with a 5 at least, and I don't know what you think about post-dilating eventually afterwards. I'm always a little bit reluctant in doing a larger balloon afterwards.
Yeah.
But 5
we just have the problem here. We have only an 014 wire. Yeah. So maybe, I don't know, because now we just will have the balloon for 3 minutes inflated. So if you would go for another lecture, we just show you, because just waiting for 3 minutes may be somewhat boring. And we can show you maybe the results after DCB application and come back after the next lecture. What do you think?
That sounds good.
Is this an option? Okay. Good.
Ladies and gentlemen, wish you all well and safe. Thank you very much for the organizing committee of Linc's kind invitation. And also thank you, Concept Medical, for supporting this symposium. It is my great pleasure to provide an update on the FUTURE-SFA and FUTURE-BTK randomized control trial on behalf of all the investigators. I have nothing to disclose. So we all know paclitaxel coated technology has beneficial effect on the patency of femoral popliteal arteries. But the controversy whether these devices associated with higher mortality remains active. Furthermore, paclitaxel has not shown promising result in the below-the-knee disease. Sirolimus technology has been used in cardiac interventions and show beneficial results. It has high potential to be an effective solution in the lower limb intervention. FUTURE-SFA and FUTURE-BTK RCT studies are set to address an important clinical question whether Sirolimus Coated Balloon provides better primary patency of the vessel compared to a conventional plain balloon. And the investigation device is produced by Concept Medical, the MagicTouch. The study design in a specific way is it is a quadruple blinded study. Participant, care provider, investigator, as well as the outcome assessor are blind to which device the patient receives. It is a 2-to-1 enrollment and CRO controlled. And the study is also having core lab adjudication. The main follow-up time point is 6 months, 12 months, and 24 months. For the SFA trial, the target subject number is 279. We only include Rutherford class 3 to 6 patients, and the target lesion should be within SFA P1 and P2 segment. It can be single or sequential lesion, but the total length is less than 20 centimeters. It can be de novo or restenosis lesion, and there should not have significant inflow diseases and at least one patent crural artery runoff to the foot. For the BTK trial, the target lesion is 219 patients, and Rutherford class inclusion from 4 to 6. Only the proximal 20 centimeter of below knee arteries were included. It can be single or sequential lesion, but within 20 centimeter. Again, it can be de novo or restenotic lesion, and there should not be any significant inflow diseases. The treated target vessel also need to have a runoff to the foot after the treatment. Exclusion criteria, the main one will be after the standard balloon angioplasty, residual stenosis more than 30%. Other exclusion criteria, including patient having very poor life expectancy, heel gangrene, planned for major amputation, or the target vessel has prior bypass surgery or previous stenting, or it is a very highly calcified lesion. The patient should also not participate in any other drug-eluting technology trial. The patient should not have contraindication to any antiplatelet agent or allergy to heparin, sirolimus, or contrast reagent. We also not include pregnant or vulnerable individuals. The major primary endpoint is 6-month primary patency of the target vessel determined by duplex assessment, PSV ratio less than 2.4. The secondary endpoints including safety, effectiveness, and functional endpoint as listed here. This is the schematic flowchart of the study. So all the PAD patients required intervention will be screened for eligibility, and those consented after the standard balloon angioplasty, they will be randomized to either the placebo or the sirolimus group. So all of them will receive a second time of balloon angioplasty, either placebo or sirolimus. The primary endpoint is a 6-month primary patency, and then all the patients will follow up to 24 months. So this study has 20 centers participated within 4 countries, including Singapore, Taiwan, Thailand, and Korea. The enrollment has commenced in August 2020, and so far 8 patients enrolled, 5 into the SFA trial and 3 to the BTK trial. and we expect the 6-month result will be ready by July 2022. Thank you very much.
Thank you very much, Dr. Hall, for this overview. And we're back to Berlin again. Ralf, you have been just giving 3 minutes time to dilate.
Yeah. So that was enough. So we just take this 5x200 MagicTouch. So that was just perfectly fitting into our lesion. So that's the result after DCB with MagicTouch and atherectomy. So I think I would not go for a 6. So I think it's just no residual stenosis. It looks quite nicely. This small haziness, so that's not a perforation. That's what I think is just this vasa vasora, which we just opened. And now I think we have to take care for the outflow and get the filter out. If you agree, I would just not exceed and do any additional ballooning. Mm-hmm. So what do you think?
It looks very good. A technical question regarding the removal of the filter. Would you leave that in place also for the balloon dilatation, or would you prefer to make an exchange, given the difficulty you had with the exchange of the L14 wire?
No, we would just. So in this case, we just left it. So the MagicTouch is available in 014, 018, and 035 trackable wires, but we just only had the long one as a 035 one. So that's why we just had the 014 still in place. Maybe it would be a little bit more easier if we would have changed before, but maybe we want to show you the final result with the filter and also just how we are going to remove the filter here. So maybe so you see here the filter probably.
Yeah.
So that's the
just above the patella
filter here.
Yeah.
At the patella, yeah, right. Just check if the filter is full or not. Due to the flow, I think there will be something inside, but not that much. Yeah, probably there is something in the filter, I think.
Yeah.
And we just will check the outflow. So what we are going to do is, so there is a retrieval catheter, but mostly it is a little bit more easy to take a diagnostic 4-French multi-purpose here. So, yeah. Now you see the filter and our multi-purpose catheter. Sometimes we just even take it out with the 035 balloon. So we are advancing our catheter, pulling on the filter. So now you see that the markers are closed. So now we just have something looking out, and the net itself is totally closed right now. So we are going to remove here. Just let me double check. Sorry. Okay, now now you see it's totally closed. Okay. Okay, so maybe we can focus here. So that's how it went out of the patient. Yes. And now we just pull it out and check whether we can see something. Yeah, so I think at the tip of the nose cone there is something, I don't know. Maybe you see something, a little bit of material inside, but not that much. So we have other devices where the filters sometimes are totally full. Mm-hmm. Now I will just check for the foot. Hier. Kann ich mal KM pur haben, bitte?
Regarding the irregularity that you saw after the atherectomy, the combination, we know that we know that after atherectomy and paclitaxel, sometimes aneurysm formation occurs. Do you have any experience with that in the long term, or maybe Edward Choke can comment on that?
Because I think. Yeah. Dr. Choke?
Hi.
So I personally have no experience?
I've not got any experience of atherectomy plus Sirolimus Coated Balloon for the long term. So my answer to that is I'm not sure if there is any similar aneurysmal effect. Sirolimus Coated Balloon.
Entschuldigung. It was in the beginning also somewhat difficult just to get a good run to the foot. We have seen this in paclitaxel, yes, but this is maybe due to the cytotoxic effect. I would expect this a little bit more with paclitaxel than with Sirolimus, but that's only my personal opinion, so I've got no evidence, and maybe just some others have some experience already, but nicht bewegen, bitte. Yeah, okay, so all vessels are patent here, which is important, I think, when you perform atherectomy, just to take care of the outflow.
Yeah, this flow phenomenon is something we have seen with the paclitaxel, especially with the crystalline based balloons, which is most of the time temporarily, but not always.
Yeah. So the one what you address is this one here, right? So that's we just have to take care that we didn't cut too deep here, and this is something maybe we can check by duplex ultrasound. But so these things here are probably really like an opening of this vasa vasora, because you see it's backflow here, and I'm just not afraid of these ones.
No.
This is something probably we will just check in the future here.
This is something that looks very similar to what we have seen in the past when we were doing remote endarterectomy, where you do a dissection with a Volmar ring, and that is exactly looking the same. So you're very close to the adventitia there, and opening up the vasovasorum, as you mentioned. But this looks very good.
Yeah.
No distal embolization, which is of course important in a patient that comes in with claudication. Congratulations, Ralf.
Thank you. So I think it was just not in terms of recanalization so fancy, but just 25 minutes of time. Sometimes you just see only the wiring, so that's why we just started already somewhat before. But I think having these data, which is just coming right up from the atherectomy trials, we just have some good experience with these calcified longer lesions. So in short lesions, I think I'm not sure whether it makes that much sense. We have some good data in common femorals, because it's just really effective tool to remove plaque material, also in combination with DCBs. But I think in short lesions, I think maybe it's some overtreatment.
Yeah.
To perform
and I think you
and DCBs. Yours, yeah, sorry.
Yeah, I think you demonstrated very nicely that also when using this Concept Medical MagicTouch balloon, it's very important to stick to our algorithm for drug-eluting balloon angioplasty, whether it's paclitaxel or sirolimus. Vessel preparation is key in order to get good results, and we know from the studies that were done in the past that atherectomy in itself is not enough to guarantee long patency, and by adding something to this with the Concept Medical balloon, everything should be work out fine in the long term.
Yeah, and I think also that the PTA time, so I think it's good to spend at least 3 minutes. So just not only very short exposure, but it's just mechanical properties of the balloon, and also just to enable this quite sophisticated technology just to get the drug into the vessel wall.
Okay. Thank you very much, Ralf.
Okay.
I think we need to go on with the program. We are just running a little bit over time. Thank you very much, and keep on the good work that you do, and take care. everybody.
Thank you to Concept Medical and to the Linc Symposium for giving me the opportunity to present some case reviews and discussion for the MagicTouch Sirolimus Coated Balloon. These are my disclosures. The first case is on the use of Sirolimus Coated Balloon for SFA and popliteal arteries, and this case demonstrates maintenance of primary patency to 2 years. This gentleman presented 2 years ago with a Rutherford 6 lesion requiring high left forefoot amputation with an open wound. He has significant stenosis of the SFA with markedly reduced toe pressures down to 6 millimeters mercury. Diagnostic angiogram confirmed the significant lesions in the SFA, and these were treated with the MagicTouch SCB with satisfactory angiographic outcomes. These are the duplex scans starting from the index duplex through to 6 months, 1 year, and 2 years. This showed that the primary patency of the SFA treated with the MagicTouch SCB was sustained through to 2 years. This slide shows the progress of his forefoot amputation wound. It took about 3 to 4 months to get to the wound to show healthy granulation. Up to the point that at 5 months, I applied split skin graft, after which the wound completely healed by about 6 to 7 months. And I'm pleased to say that I've just reviewed him this month, and the wound remains healed at 2 years. So this is him in the clinic at 2 years, and I'm pleased to say that he's now back at work as a taxi driver for more than a year now. The second case is on the use of Sirolimus Coated Balloon for below the knee arteries, and this case demonstrates maintenance of primary patency to 1 year. This is a patient who presented with gangrene of the right big toe with ascending infection. And the duplex scan shows significant distal disease, which was confirmed by the diagnostic angiogram. The strategy was to achieve inline flow down the anterior tibial artery and to maintain the anterior tibial artery patency for as long as possible, because wound healing was expected to take about 4 to 6 months. The diffuse lesions in the anterior tibial artery were successfully treated by plain old balloon angioplasty, followed by Sirolimus Coated Balloon. Sirolimus Coated Balloon was applied in this case to the entire length of the ATA, from proximal ATA to mid-ATA down to distal ATA. These are the duplex scans at index and also at 6 months, which showed that the anterior tibial artery had remained patent with no significant lesions and triphasic waveforms distally in the dorsalis pedis at 6 months. This sustained patency is necessary because, as expected, the wound took about 5 months to completely heal, and if the anterior tibial artery had restenosed during this time, then the wound healing would probably stall at some point. This is the duplex at 12 months, which I'm pleased to say shows that the ATA had remained patent, and again, triphasic waveforms were seen distally in the dorsalis pedis. The third case is also on Sirolimus Coated Balloon for BTK arteries. In this case, demonstrates absence of distal embolization or slow flow phenomenon after application of the Sirolimus Coated Balloon. This is a case of an 82-year-old who presented with extensive toe gangrene and long anterior and posterior tibial occlusions. And the strategy was to try and achieve flows into both anterior tibial artery and posterior tibial artery, as the foot wounds post-angioplasty was expected to be large and it would take some time to completely heal. So we needed to achieve patency for as long as possible. Diagnostic angiogram showed the long CTO of the ATA and PTA with distal reconstitutions at the plantar arteries and also the dorsalis pedis here. So this patient had good distal targets to try and achieve patency down both tibial arteries. This is a patient who presented with gangrene of the right big toe with ascending infection. And the duplex scan shows significant distal disease, which was confirmed by the diagnostic angiogram. The strategy was to achieve inline flow down the anterior tibial artery and to maintain the anterior tibial artery patency for as long as possible, because wound healing was expected to take about 4 to 6 months. The diffuse lesions in the anterior tibial artery were successfully treated by plain old balloon angioplasty, followed by Sirolimus Coated Balloon. Sirolimus Coated Balloon was applied in this case to the entire length of the ATA, from proximal ATA to mid ATA down to distal ATA. These are the duplex scans at index and also at 6 months, which showed that the anterior tibial artery had remained patent with no significant lesions and triphasic waveforms distally in the dorsalis pedis at 6 months. This sustained patency is necessary because, as expected, the wound took about 5 months to completely heal. And if the anterior tibial artery had restenosed during this time, then the wound healing would probably stall at some point. This is the duplex at 12 months, which I'm pleased to say shows that the ATA had remained patent. And again, triphasic waveforms were seen distally in the dorsalis pedis. The third case is also on Sirolimus Coated Balloon for BTK arteries. In this case, demonstrates absence of distal embolization or slow flow phenomenon after application of the Sirolimus Coated Balloon. This is a case of an 82-year-old who presented with extensive toe gangrene and long anterior and posterior tibial occlusions. And the strategy was to try and achieve flows into both anterior tibial artery and posterior tibial artery, as the foot wounds post-angioplasty was expected to be large and it would take some time to completely heal. So we needed to achieve patency for as long as possible. Diagnostic angiogram showed the long CTO of the ATA and PTA with distal reconstitutions at the plantar arteries and also the dorsalis pedis here. So this patient had good distal targets to try and achieve patency down both tibial arteries. The anterior tibial artery was successfully crossed in an antegrade fashion. With the wire successfully crossing into the dorsalis pedis here. The DP and the anterior tibial artery were successfully treated with the non-compliant plain old balloon angioplasty, including up to the proximal anterior tibial artery. So with this, we were able to achieve reasonable flow down the anterior tibial artery, right down into the dorsalis pedis. So after this, the dorsalis pedis was treated with the MagicTouch Sirolimus Coated Balloon, as you can see here. And the whole of the anterior tibial artery, starting from the distal anterior tibial artery, was treated with the MagicTouch Sirolimus Coated Balloon. In the distal artery, we treated with the 3mm Sirolimus Coated Balloon. Proximal anterior tibial artery was also treated with a 3mm MagicTouch Sirolimus Coated Balloon. We then turn our attention to the posterior tibial artery and successfully cross the wire into the lateral plantar artery. For the posterior tibial artery, we treated it with POBA, with a non-compliant balloon, 2.5 millimeters at the bottom. And the entire PTA was treated with a 3mm non-compliant POBA from the distal PTA down, up into the proximal posterior tibial artery. We decided not to apply MagicTouch Sirolimus Coated Balloon to the posterior tibial artery, mainly due to cost constraints for this patient. So here you've got one tibial artery treated by MagicTouch SCB and the other treated by plain old balloon angioplasty. And when you compare the two going down side by side, you can see that there is no slow flow phenomenon. and there was no distal embolization. Starting from the top, going down to the lower leg, there was also very similar flows down the anterior tibial artery, similar to the posterior tibial artery. And as you can see here, all the way down to the foot. So in summary, the MagicTouch PTA SCB showed good primary patency in terms of medium-term outcomes up to 1 to 2 years, and there was no distal embolization and no slow phenomenon even when applied to small below the knee arteries. Thank you very much.
It's a great pleasure for me to present our Sirona trial design. Sirona is a randomized controlled head-to-head comparison of the MagicTouch Sirolimus Coated DCB against paclitaxel DCB. In this trial, we are looking at safety and efficacy of the MagicTouch PTA balloon. This trial will be patient-blinded, obviously investigator unblinded, and will be performed in 29 sites in 2 countries. Here you see our study sites in Germany and Austria. They are widespread over the country, and we are going to recruit more than 480 patients. Therefore, we have this high number of 29 sites. Here you can see our trial design and endpoints in brief. We have secondary and primary endpoints. Our primary endpoint is a primary patency as efficacy endpoint and a composite endpoint of for safety. We have a long follow-up from 1 month up to 60 months, meaning 5 years. Here again, our endpoints. Primary endpoints will be reported after 12 months. For efficacy, we are looking at primary patency. As safety endpoints, we have a composite endpoint from freedom from device and procedure-related death at 12 months, and as well freedom from both target limb major amputation and clinically driven target lesion revascularization. As second endpoints, we have the TLR rate, the sustained clinical improvement. We're also looking at walking capacities, and also the duplex defined binary restenosis, as well as questionnaires for the patients for the quality of life. Our eligibility criteria include, for inclusion, mainly claudicant patients from Rutherford 2 to 4, and we want to focus on de novo restenotic and restenotic lesions in the SFA. Here again, our study workflow. On one detail I want to one detail I would like to point out, that is when we do the randomization. And actually the randomization in this trial will be performed after predilatation and right on the angio table. This is probably special for this trial, just to ensure that both study arms are really predilated the same way and treated the same way in both arms. The index procedure, here it is important that for the predilatation, we request long predilatation time for optimally for 180 seconds in both study arms. And we believe that this is a very important detail to reach the best possible long-term results in terms of freedom from TLR. The follow-up period goes up to 5 years. Our primary endpoint will be reported at 1 year, and we will have 4 on-site visits for this trial, all including each time a Doppler examination as follow-up. So why do we do now this trial? We are all aware about the discussion on the association between paclitaxel dose and mortality risk. The Sirona trial is currently the first trial worldwide that is ready to be initiated to collect additional evidence on Sirolimus Coated Balloons. And therefore, I think it's very important to have a head-to-head comparison about the efficacy and safety. And we are very eager to hopefully start within the next 2 weeks with our first patient in for the Sirona trial. Thank you.
Good morning, everyone. My name is Stefano Barco from the Clinic of Angiology of the University Hospital Zurich, and I'm very happy that you have me here to present key elements of the study design of the SirPAD phase 3 trial. So these are my disclosures. First of all, some key elements of the rationale of the SirPAD RCT. First of all, why did we decide to test Sirolimus Coated Balloons? Mainly for the characteristics of product, and you have already heard something about it from the speakers before this presentation. So I will not go in detail into that. Second, because we need a large trial with hard clinical outcomes, given that the trials that have been published so far adopted surrogate outcomes, primarily echocardiographic or angiographic, and add many exclusion criteria. And this, of course, limit the external validity of the study. Third, because we know from the experience in the cardiology field that Sirolimus coated stents and balloons might be better than others. And finally, because we have signals from other PAD trials that it's unclear whether paclitaxel balloon may impact long-term survival in PAD patients. First of all, I would like to reiterate the concept of an all-comer trial. So in this study, in the SirPAD trial, we aim to maximize enrollment by limiting the number of inclusion criteria. We have primarily two key eligibility criteria: endovascular angioplasty needed for an inguinal PAD, and second, patients should not be participated in other interventional studies. Having said that, of course, it's important also to remind how we define the target lesion. So target lesion is the main lesion considered responsible for signs and symptoms and fulfills this angiographic criteria, that is a stenosis of at least 50% in at least a single plane of the femoral-popliteal arterial segment or below the knee. And these are very easy criteria that, as said, aim at maximizing enrollment. We have two study groups in the setting of a randomized 1-to-1 phase 3 open label and investigator-initiated control trial. Intervention group is composed of MagicTouch PTA Sirolimus Coated Balloon, and in the comparator group we have any available uncoated balloon catheter approved for PAD patients in Europe. And for this study, as already mentioned, we adopted a hard clinical outcome combining two major adverse limb events that are unplanned major amputation of the target limb and endovascular or surgical target lesion revascularization for critical limb ischemia, this occurring within 1 year of enrollment of randomization. Key secondary and safety outcomes are listed here. I think it's important to also emphasize that many of them are relevant and clinically important outcomes, including death from all causes and death and MLAE within 1 year of randomization, as well as SAEs and SA device-related events. This is a brief overview of the study flow. You see there are two different screening phases. The first screening phases take place in the outpatient clinics or the emergency room, and patients are referred from our clinic, from our hospital, or from satellite hospitals for echographic evaluation of PAD. If the target lesion is suspected, then patients are referred for an angiographic exam, and the second part of the screening takes place in a cath lab on the day of potential randomization if the angiographic criteria are fulfilled. On that day, patients are then randomized to either Sirolimus Coated endovascular treatment or non-coated endovascular treatment, and the primary efficacy outcome is measured and is evaluated within 1 year of enrollment. As already mentioned, we included death as an important safety outcomes within 2 years of enrollment in light of prior experience with paclitaxel coated balloons. There is also some other element of novelty, and this is our predefined hierarchical analysis, which starts as a non-inferiority analysis for the primary efficacy outcome within 1 year. If this is confirmed, then we are allowed, at no cost in terms of p-values and sample size, to perform 2 additional hierarchical analyses. First, superiority for the composite of unplanned major or minor index limb amputation and any target lesion revascularization, and second, superiority for the primary efficacy outcome within 1 year. We will perform 3 different efficacy analyses in the intention to treat, as treated, and per protocol population to test for heterogeneity. And the status of the study is actually very good. We included 77 patients in 2.5 months despite COVID. And just a few words on the assumption that we made for the definition of the sample size of the SirPAD trial. So we assume a 10% event rate for the MALE within 1 year. And this would be supposed to be the same in the 2 groups. And we set the non-inferiority margin at 5% for the absolute risk difference of the 2 groups. So to confirm primary objective of the study, we will need approximately 1,200 patients, considering also dropout, that is 600 patients per group. And we are expecting to perform the first interim analysis after 600 patients, 300 per group, in approximately 12 to 18 months. And the publication of the study design paper is pending, so very soon you will be able to read more details on the study design of the SirPAD trial. And with this, I would like to thank you very much for your attention. This is the whole study group led by Professor 𝐜𝐤𝐫𝐞, and this was a picture made on the day of the first randomization on 3rd of November. Also important to emphasize, all our medical personnel is involved in the study to improve and to maximize enrollment in the setting of an all-comer trial. So thank you very much. I'm happy to take any question from the audience.
So we know that drug elution technology applicable in BTK relies on drug eluting stent, resorbable drug eluting scaffold, and drug eluting balloon. But due to the length of the lesion in BTK and due to the distality involved, drug coated balloon best matches the complex anatomical scenario in this illness. We know the last data regarding paclitaxel eluting balloon showed efficacy in the AQUART2, in the AQUART-BTK, and the IMPACT-BTK. All the 3 studies produce a reduction in late luminal loss in favor of drug-coated balloon compared to POBA without any safety concern, with major amputation more close to 0 than 1. But Sirolimus is the next step forward in this treatment. We know that it's a cytostatic drug compared to paclitaxel that is cytotoxic. We have an increased margin of safety, 10,000-fold compared with 100-fold, and there is an anti-stenotic action which is optimal. And the difficult is the fact that the Sirolimus is more difficult to be absorbed compared to paclitaxel. But we also know that we can leave the drug inside the vessel wall like a drug reservoir storage. The velocity of the modification to this reservoir to an active form, the velocity is important for the lasting effect of the drug. So the technology is really important for DCB. And for Sirolimus, the Nanolute technology was really important because we could reduce the dimension of the Sirolimus from 43 to 0.35 microns, embedding the Sirolimus inside a phospholipid layer with a hydrophilic head and a lipophilic tails, going inside the vessel wall and penetrating the intima, the media, and the adventitia with a more, let's say, optimal distribution in these three layers compared to paclitaxel, and lasting effect for an antiproliferative long effect. So the debate BTK dual is a randomized head-to-head comparison of paclitaxel versus Sirolimus coated balloon for infrapopliteal artery angioplasty. The study is a randomized 1-to-1 multi-center in 4 centers in Italy, and 172 patients with the CLI will be randomized. You see, this is the flow chart of the study. We go immediately to the inclusion and exclusion criteria. We include CLI patients, Rutherford class, major equal than 4, stenosis occlusion of at least 4 centimeters with a Kawahara classification 1, 2, but including also the tarsal artery patent, and of course an optimal balloon angioplasty before randomization. We excluded the life expectancy less than 1 year, a pre-planned major amputation, allergy to paclitaxel or Sirolimus, contraindication for dual antiplatelet treatment, and need for BTA angioplasty to restore the flow in the arch. You see the Kawahara accepted here is type 1, type 2A, and type 2B. Type 3, the desert foot is not possible to enroll, but if we have an anterotibial filling the tarsal that is filling the arch, then we can include the patient. Defining the optimal balloon angioplasty in the study is a less than 30% residual diameter stenosis by visual estimation without flow-limiting dissection, but also by duplex, pulsatility flow throughout all the treated segment with a PSVR less than 1.5, which is really important for our best strategy. The reference vessel diameter in this study is performed not only by angio, but by duplex, assessing the lumen vessel size, not the vessel size and not the lumen vessel size. And this is the place where we have to delete the drug. So the measurement will be, in this case, 3.2, according to 2.6 of the angiography. We will follow the duplex and not the angio. Not to undersize the treatment, but also if we guide our intervention, like in these tandem lesions in the anterotibial, with a 3.0, we had an acceptable result, but also we check by duplex, there is an acceleration. Then we go back with a 3.5 measurement, 3.3, and we go with a 3.5 balloon. In going with 3.5 balloon, we have the acceleration disappeared, and so we have to continue the intervention with DCB, and then with an optimal result, immediate and 6 months after. The primary endpoint of the study will be the late luminal loss at 6 months by control angiography, and secondary endpoints will be 12 months vessel occlusion, major amputation at 12 months, and clinically driven target lesion revascularization. The sample size, according to a late luminal loss for this type of population of 0.5 for a paclitaxel coated balloon like the ACOART reported, and considering 80% power and 10% of superiority or inferiority margin, we need 172 patients like a sample size. This is an example of very ugly anterotibial artery occlusions treated with Sirolimus coated balloon, optimal final result, and you can see the angiography and the duplex at 12 months giving a biphasic, triphasic flow from the proximal to the distality of the artery. So in conclusion, DCB is the proper drug-eluting device to match BTK intervention. These studies highlight the patency advantage of paclitaxel over POBA, and the debate BTK dual will provide a head-to-head comparison between paclitaxel and Sirolimus, but a dedicated interventional strategy included in the study will limit procedural bias and will make the result more reliable. Thank you.
Thank you very much to all the speakers. We now still have a couple of minutes to discuss some of the presentations. And first of all, I would like to congratulate Concept Medical and all the contributors to all the scientific work that is currently done on the MagicTouch balloon. I think it has always been very important to perform randomized controlled trials with a long follow-up, but I think it has become even more important after the Katsanos paper.
So, may I ask you just one thing that was not clear to me. We are checking long-term mortality, so 60 months in the Sirona and also in the SirPAD studies. Just a suggestion, you want to check the difference in mortality, but then the randomization should take care of left ventricular ejection fraction, the presence of heart failure, and the presence or the development of renal insufficiency. Otherwise, we go back to Cazzano's mistakes. And in 6 years, we have to face the problem that paclitaxel or sirolimus have a higher mortality, but at the end, the randomization was performed for lesion and not for patients. So if you want to check mortality at 6 years, you have to take in consideration the baseline predictors of death in this kind of population.
Of course, if you randomize, this should all more or less work out in the same way for both groups, but it's something that you absolutely need to check afterwards if those characteristics of the patients were actually the same or not, in order to explain an overkill, so to speak, in one of the two groups. What I like about your study, Francesco and Ulf, is the comparison with something that we already know that is effective. Do we still need other trials, do you think, comparing to just plain old balloon angioplasty?
Well, actually, at this time, I can tell you maybe we need a big trial to see if the advantage in patency it's automatically transducing in an advantage of clinical points. And then we will need a study with hundreds of patients. But at the end, yesterday, I saw that even in the Tango trial, the target vessel area loss in the POBA group for 48%, and it's the same of the Aqua BTK. So I think that now we know that real BTK situation treated with balloon angioplasty, provide a target vessel area loss of 50%. So half of what we gain, we're going to lose with POBA. And we have very important signals that we're using some types of drug-eluting balloon, not all, but sometimes of drug-eluting balloon, we can reduce to 5 to 20% of this loss. So it's really an important signals. I know that in our hands, we have the 0 major amputation, and we have a very strict protocol in wound care. And of course, we should do a big trial, but I don't know if the companies are in this direction.
Thank you, Francesco.
Probably back to your question. You asked if we need also other trials in addition. Well, I think Sirona, for example, is a good head-to-head comparison. But what we have seen today in our live case is also that vessel preparation, meaning atherectomy, indeed also plays a big role in our way how we treat today peripheral arteries. And therefore, I think the combination of DCB with atherectomy, and this in the comparison would be also a very interesting topic, which is probably not yet covered.
Thank you.
Maybe to give you my perspective, Josh, briefly. Well, I think that this trial program set up by Concept Medical is really a very robust, I must say, very impressive program. The real strength is that we are dealing here almost exclusively, actually, we are dealing with randomized trials. We are, with the exception of the very first in men trials, which of course had to be single arm, all the rest is randomized against some sort of predicate treatment, which I think is, scientifically speaking, very important. It is a big series of trials. Of course, randomizing against a POBA is, classically speaking, the proof of concept, which we need to do. Randomizing against paclitaxel devices is probably more the real-world approach. So I think what's tried here is we are trying to do everything in parallel. It reminds me a little bit about finding a vaccine against corona. So we do all the phases in parallel here, very ambitious, but scientifically speaking, I think very strong at the same time.
I fully agree, and I really want to compliment Concept Medical with this multi-directional approach that they are doing. I want to thank them all also for the support for this symposium. Of course, all the speakers I want to thank for their contribution. And unfortunately, we're running over time, and we already got some extra minutes from the course director, but we now really need to wrap up. Thank you very much all, and enjoy the rest of Linc, even if it's in this way. I would rather be in Leipzig at this moment, but that will be for next year.